Okay, good morning, everyone. We are so excited to have you join us for our next presentation, Zero Suicide for Indian Country, Making Suicide a Never Event. And we have Ms. Sade Ali here, Heart of the Hawk, will be our speaker for the next 55 minutes. I'm Jenna Heiss. I'm the Implementation Director for Suicide Prevention at the Office of Mental Health Suicide Prevention Center. And I am going to start out with just a few announcements here. You may have heard them, excuse me, if you were in the last session, which of course was excellent and beautiful. Thank you so much, Keegan. We are doing, of course, our continuing education units, and you will be able to find information for that on the main screen. If you go out of the auditorium, there will be information along the top and at the very bottom of the screen about that. You will be able to find this PowerPoint presentation and all handouts and be able to put them into your takeaway bag. I will be monitoring the chat today while Sade Ali is speaking. And so if you have any questions, please feel free to put them into the chat. But these sessions are all muted for the entire time. So at the end of this session, we will stay a few minutes afterward, and you are free to hop off at 9:55 and attend your next session. But Ms. Ali has graciously said she would stay for a few minutes extra and answer questions. So I would be happy to have your questions answered at that time. And excuse me, I think without any further ado, we will just get started here. And if you have housekeeping questions that I might have forgotten, you just put those in the chat. So I will just turn it over to the most wonderful and amazing Sade Ali, Heart of the Hawk.
Well, Lali and Jenna, it's really an honor and a privilege to be here with you this morning and with the state of New York. Good morning, relatives. My name is Heart of the Hawk. I am Mi'kmaq First Nation from a small reserve in Nova Scotia, Canada, what's now known as Nova Scotia, Canada, we call Mi'kmaqi. And I am the tribal lead from the Zero Suicide Institute, a worldwide organization providing training and technical assistance for folks who want to make their systems safer for people experiencing suicidal thoughts and behaviors. It's a real honor and a privilege to be here with you this morning. I want to open in a good way. If you are Indigenous, you know that this is our way, that we always open any gathering or any celebration or any time we get together in what we call a good way. And I'll first acknowledge the ancestors of your land, the ancestors of all of the Indigenous people who once were caretakers of the land now called New York, and ask for their blessing on this particular gathering, the state of New York's conference called AIM for Zero. And I love that. I got my little swag. Jenna, thank you so much. It's a great aim to aim for zero suicides in the state of New York and make suicide a never event, and especially with our Indigenous people. And I really want to ask a blessing on the ancestors of the land on which I reside, and that's the land of the Quinnipiac. Some people think it's a university or a pizza place or an avenue, but it really is the name of the Indigenous people who once were caretakers of this land. So I want to acknowledge those ancestors as well. And no matter where you are on Indigenous land. And I want to ask that Creator bless every single one of us, especially in these very trying times, in these times of the pandemic, when we're trying to do our work and have to come up with different ways in which to do it, in which to reach the people that we serve. So Creator bless every single person who came to this conference and who are with us this morning in this particular presentation, whether they, no matter where they come from. If you are working with Indigenous people, we ask that Creator bless you with an open mind and open heart so that you can hear this information this morning. And if you are the first people, I say walali to you. Thank you all for coming. And we hope that you get everything that you need from this particular conference. It's a very important discussion. I want to also start this presentation by acknowledging the fact that our people are going through a great trauma right now. And we always knew that there were children that weren't accounted for, but it's coming to light more and more every day. So far, they've found almost 7,000 children who were buried in mass graves in places that were called schools, where our children were taken and away from our families, away from kinship model, away from ceremony and their names and their spirituality. And they're being found more and more, and every place there was a so-called boarding school or residential school, and they weren't really schools. They were places where our children were taken, and we're finding those the remains of these poor babies, and they're being returned to their tribes. The tribes are claiming them and bringing them back to the ancestral land. So we want to honor and remember them. And as our Secretary of the Interior, our own Deb Holland, starts her investigation of the sites around Turtle Island, where they're going to be finding even more children. For those of you who are working with us in behavioral health or in physical health, a reminder that there's a great trauma every time that one of these children is found. So please keep that in mind. And we'll talk a little bit more about trauma and its impact on suicidality in my people. Our objectives for today are really kind of simple. At the end of this presentation, we hope that you'll be able to differentiate culturally relevant screenings that resonate with the tribes and the nations that you may serve, and their understanding of the loss of life and any taboos they may have around language, that you'll be able to incorporate an understanding of your role in safer suicide care, even if you don't provide behavioral health services, or even if you don't provide behavioral health services specifically for Indigenous people. You need to know that New York is the third in the country for urban natives. Now, there's 75% of us live off our ancestral lands. I do. Many of us do. We do not live on reservations. We live out in the community in urban areas. And New York is number 3 in the country after California and Arizona for people living off of their ancestral land. So keep that in mind as we go forward today. And we hope that at the end of today, you'll be able to apply the 7 principles that we call the 7 elements of zero suicide in ways that may be culturally resonant with any Indigenous communities you serve and based on your services. I want to start out by saying there's no such thing as Native culture. I was in a National Academy yesterday. I did a National Academy for 2 days, and the Yakama Nation was there from Washington, from the state of Washington. Their culture is very, very different than my culture, or than the cultures of the people in the state of New York, the nations, the sovereign nations in the state of New York. No such thing as Native culture. We are 574 federally recognized tribes. We have villages, we have bands, and we have confederacies. You have a confederacy right there in New York made up of 6 nations. And every single one of them has a different culture. And so there's no such thing as Native culture. It's a beautiful patchwork of of different cultures, and each one of them is different. New York State is the ancestral land of 8 of these federally recognized nations. Some of you probably know of them: the Cayuga, the Onondaga, the Oneida of New York, St. Regis, Mohawk, Seneca, Shinnecock, Tonawanda, Band of Seneca, and the Tuscarora Nation. The Unkachug, our nation, is state recognized. And there's lots of little bands of these nations residing in the state of New York. And as I said, 75% of us live off of our ancestral lands. And you have the 3rd largest population of us. Every single one of us has our own language, our own healing ways, our own medicines, our own creation stories, our songs, our dances, our colors, our beadwork. But there's some what I call universal Indigenous truths. And these truths go beyond just the nations here on this side of Turtle Island, what we call Turtle Island, which is actually all of North America, Central America, and the Caribbean. I would extend that out to our relatives in the Pacific and in what is now called New Zealand and Australia, because I had a chance to keynote a conference, the World Indigenous Suicide Prevention Conference in Perth, Australia. And if it wasn't for the accents, I would have thought I was still in the US. One of the elders from New York, I think he's either Oneida or Seneca, Clayton Logan, a veteran in his 80s. He was extremely honored veteran there in New York. And he was actually brought over for that conference as well. So I got a chance to hang out with Clayton and to meet him and to talk with him about what's going on up there in New York. So we have a big family, and we call each other relatives, and there's a reason for that, because we believe that we're all united, and we're all family. And I didn't see the fullness of that until I really went to Standing Rock and was there at the camp where I saw all of us working together. And it was a beautiful thing. One thing I need you to take away, and this goes for any time any of you are working cross-culturally: one size should never fit all. I am with the Zero Suicide Institute, and we have a framework of elements that together have impacted the amount of reduced the amount of loss to suicide in many systems who follow this framework, who use all of the 7 elements together to craft a framework for safer suicide care for the people that they serve in their health and behavioral health care systems. And there's been a lot of success with that. And I mean, Jenna has done that herself, and she understands how powerful it is to use this framework for healing and for identification and for treatment of people who are experiencing suicidal thoughts and behaviors. But one size should never fit all. And the beauty of Zero Suicide is that you can tailor it to meet the needs of your system. So keep that in mind. It's a wonderful framework, but I'm going to talk to you about its resonance in Indian country. The universal truths that I believe in, that are fairly consistent across even the most diverse nations, and I'm even talking about the Māori people in what's now called New Zealand, and the Aboriginal people in Australia. There's some universal Indigenous truths. We all believe in a power and have reverence for a power greater than ourselves. We might call that power different things: a great spirit, great mystery, creator, God. It doesn't matter, but we believe that there's a power greater than ourselves. We honor the elements of of nature. We honor Mother Earth, Father Sky, Grandmother Moon, Grandfather Sun. Those are, we might call them something different, but we really honor and revere the earth and every living thing, because we believe that everything has a spirit and that we're all related as a result of that. From the animals to the trees, everything has a spirit. We always honor those who came before us because we stand on their shoulders. And just like I asked permission of the ancestors this morning to allow us to go forward and to really share and to gain acceptance, we really honor those ancestors. And we have traditional medicines and healing ways that are thousands of years old. My own tribe, we can trace our existence back to the end of the last ice age. So we're talking about 20,000 years. And there is, those of you who may have watched Curse of Oak Island on the History Channel, that's actually in Nova Scotia, part of Nova Scotia. And they've said that several times during the course of that particular show. And they acknowledged that our people were on this earth, what we now consider this earth long ago, and our healing ways are ancient. And are they studied in medical journals, and are there clinical trials? Are they peer reviewed? Absolutely not. But they worked then, and they can work again. I just was sent a paper just before this conference started, from the NIMH, National Institute of Mental Health, and they were talking about um, how the ancestral ways, if we go back to the ancestral ways with Indigenous people, that's very healing. I've been saying that for a very long time. I'm just not a scientist. I'm not a researcher, but I've been saying that for a long time, and the researchers came along and kind of validated that. The closer we are to our root system, the stronger we become. Many of us, and another universal truth is that many of us believe that every single thing we do impacts us 7 generations into the future. This conversation that we're going to have today will impact us 7 generations into the future. Why? Because you'll say something, or you'll talk about something that you heard today, and that will be passed on and passed on and passed on, and hopefully something is going to resonate out. It's like the butterfly effect. Just the flapping of those wings resonates into the future. We believe that what we're talking about today, what we do today, is going to impact us 7 generations into the future. If you're working with us, one of the main things to know is that we have survived layers upon layers upon layers of trauma. And in order to work with us in a culturally resonant and safe way, you're going to have to understand that we are survivors of trauma. I didn't tell you who I was, and I'll tell you right now. I told you I was Mi'kmaq. That's the most important thing you need to know about me, because it informs everything I am. However, I'm also someone in long-term recovery. I had a pretty severe heroin challenge back in the late 60s, and I got into recovery on the 13th of February in 1970. And I've maintained that recovery for almost 52 years. I got into the field in very early recovery, and I've been there ever since. I got into behavioral health, into addictions treatment. Back then, the only degree you needed to have to work in addictions treatment was the degree from the School of Hard Knocks, and I had a PhD in that. And I got into the field, and I've stayed in the field since then. But I'm also someone who's living with what is known in the field as a severe mental health challenge. And I've been living with that. I was diagnosed in 1992 with bipolar challenge and decided that I had knew enough about it by the time I was diagnosed to know that I was more than that challenge. And so I've lived my life paying very, very close attention to my challenge and knowing when things were not starting to go well, and I would do something about that. But I'm also a person in long-term recovery from multiple suicide attempts. The thing you need to know, though, is that that's not uncommon for people who are either survivors of the residential schools, what they were called down here were boarding schools, or first or second generation. If you had a parent or parents who were in those schools, because they weren't really schools, they were places that deprogrammed or these babies, and they were told consistently that there was something wrong with them for being Native and they needed not to be that. And if you are first generation or second generation away from that, there's a very good chance that you had or still have some challenges that you're dealing with. I'm not unique. I, that's the sad thing about that. I'm not unique. And trauma plays a huge part in that. I still deal with PTSD. It's still hard for you to come up behind me and scare me. It really jars me. But those kinds of things are not uncommon in our people. So if you don't understand that and you're asking what's wrong with you instead of what happened to you, that can be very traumatic. So if you don't understand that there's layers upon layers upon layers of intergenerational and historical trauma, there's also layers upon layers of modern day trauma. So some of the things that happened to us, there were multiple genocidal attempts to eradicate us. This is not taught to you in school. So I'm putting the blame exactly where it should be. It's not being taught in school. The history of what happened to Indigenous people is not. But the manifest destiny where they said if we are Christian and you're not, then we can take whatever you have. Although we never felt we owned anything, there was this concept called manifest destiny and the doctrine of discovery that was actually one of the papal bulls that we hoped would be rescinded, but it wasn't. There were chemical efforts to eradicate us. The smallpox blankets, people may have heard about that. The residential or boarding school era is probably the biggest, where you take a child away, the children away from a group of people and force them to be part of another. That's by the United Nations definition, genocide. There were Indian wars, forced relocations by many of the tribes. The Dawes Act, where our land was taken and we were put on a roll. And we're the only, if you think about it, we're the only nationality of people in the United States who has to carry a card to prove who we are. The destruction of our food sources. The buffalo was destroyed in the plains area. And it was a way to rid the country of us. Our healing ways were criminalized until the late 70s. So we couldn't do sweat lodge, we couldn't have a talking circle, we couldn't gather together. And so our healing ways and medicines were criminalized. And then that colonization that forced forcing our people to adhere to other ways rather than our own. Some of the modern day traumas we experience are, some may have heard about, our missing and murdered Indigenous relatives. We used to call it missing and murdered Indigenous women and girls, and it's expanded to now our relatives, because men are coming up missing at all as well. The destruction of our water supplies through assault on them, oil pipelines, tar sands, and some of the tribes, like the Diné Nation, still has undrinkable water. Up on my side of Turtle Island, there are still uh, boiled water. We can't drink our water without boiling it first. There's ignoring of our treaty rights and the sovereignty of tribal nations. Your nations up there in New York are sovereign. These are countries, basically, and they have their own governance and their own way, their own laws, and their own treaties. But a lot of these have been ignored. A lot of our reserves have food deserts. So the nearest grocery store is 30 miles away, and the food there is not really good. There's no fresh fruits and vegetables. So a lot of it is not really good for us. It's not healthy. I talked a little bit in the beginning about the mass unmarked graves with the remains of children as young as 3 being discovered. And why would you need a graveyard at a school? Would you send your child to a school that has a graveyard attached to it? You wonder about that. We've really struggled with Not Your Mascot, with, Halloween is coming up, and every time we see a person in a Indian costume, it's usually very, very disrespectful, and we're not mascots. Cultural appropriation is a big issue, and of course, again, colonization. There's been many assaults on us, and this really creates trauma amongst our people. So we're not only talking about the trauma that is passed down generationally, and some of you who have worked in trauma-informed system know that that it's genetic. It's blood memory, but there's also modern day trauma that we're experiencing right now. Best and promising practices for the implementation of zero suicide in Indian country is my heart child, not my brainchild, but my heart child. And is a document that I was able to create as a result of my contract I had with IHS through the Zero Suicide Institute to work with their awardees to implement zero suicide. And I was able to go around this side of Turtle Island and work with IHS and help tribes implement suicide safer practices, because most folks know that we have probably doubled the rate of suicide in Indian country. And sadly, it's mostly our adolescents and young adults. Whereas in the general population, it's folks my age and maybe a little bit younger who are ending their lives. For Indian country, it's the younger people, and we really need to pay attention to that. So zero suicide, some of you may be familiar with zero suicide. Some of you may be implementing zero suicide. It contains 7 elements. There's a ton of research around zero suicide, and it's shown to significantly reduce loss to suicide in healthcare systems and behavioral healthcare systems. And something you may not know is that more folks end their lives who have seen a physical health provider in the last 30 days than the folks who actually have seen a behavioral health provider. So physical health, clinics, primary care, hospitals, EDs really need to pay attention and do good screening and ask the questions that will lead to good care. Zero suicide uses evidence-based screening and assessments to judge risk. And they use specific treatments, suicide-specific treatments for those at risk. And it wraps people and families and communities in safe care that keeps them connected to that care. And it really is a system that's person and family directed. And one of the ways that that illustrates that is the safety planning aspect. So everybody who comes into a system that is doing zero suicide, that is implementing zero suicide as a way to make their care safer, has a safety plan. And that's created not by the clinician, but by the person, or by the person and family. It addresses lethal means safety and transitions people safely from one level of care to the next. And those kinds of transitions, especially for folks who are experiencing suicidal thoughts and behaviors, are really important, because you don't want to assess somebody for suicide risk and then send them out into the community with no supports. That's like sending somebody out on fire. So zero suicide as a framework has shown tremendous efficacy in the field. It's really effective, except that none of these evidence-based screens or assessment or treatment were validated on us. None of them. So for the general population, this is so powerful and so helpful, but none of them were validated on us. Many of our languages, my language does not have a word for suicide. And if there is a word for suicide, in many of the tribes I worked with, it's taboo to even talk about, because we have this concept in our systems, in our communities, called naming. Naming is so important. So if you have a child born into the tribe, and it's the elder or the grandmother or the people of medicine who actually name that child, and that's after, praying and holding the child and asking the ancestors to uh, give you a name. It's a very important thing to do. Why? Because a name aspire to, and usually they're given names that are very powerful, and these children grow up in those names and they become self-actualized. Well, in our tribes, if you name something, if you call something to you, it gives it life. And that's the last thing we want to do around suicide, is to bring it to the people. And in some tribes, they call it ghost sickness. So they don't even talk about someone who died by an illness. So there's a period of time when you don't call their name and you don't talk about them, and then you celebrate them. It's usually about a year when they make their journeys. We believe that they journey to Creator. Zero suicide can be indigenized, and I was able to work with our tribes and with our team to do that. And we believe that there's the circle is a very powerful tool, because there's no beginning and there's no end. And if we're sitting in a circle, there's no big person and no little person. We're all the same. And as we move around the circle, everybody's voice is important. And I put each of the elements of zero suicide into that circle in the 4 quadrants. The 4 directions are very sacred for us. There's medicine in each of them, medicine of the emotional, the mental, the spiritual, and the physical. So each of those elements of zero suicide is in the medicine wheel, and it's all medicine. We believe that zero suicide is a framework, is a medicine that we can see as resonant with us. And a lot of times Indigenous communities didn't think zero suicide was for them. And then when we developed the toolkit, people can see themselves in it a lot better. When we're going to talk a little bit about the elements. I want to make sure I've got a little time here. So when we talk about the first element is lead, and those of you who are familiar with the framework know that lead is a system-wide culture change. When you're doing this work, it's changing your culture, committed to reducing suicide deaths. And one of the things that you need to do is identify leaders in your system, and a clinical lead, a respected clinical lead, people with lived experience, your IT folks, somebody involved with continuous quality improvement, CQI, or risk management in your system. However, if you are working in Indian country, what you need to do is to make certain that you start with the community. you really want to make certain that the community is part of that too. So even if you're not an organization that specifically works with Indigenous people, please do uh, consider, if you do have a population of Indigenous people that you're serving, please consider having someone from the tribal community involved in your team. If you are thinking about doing zero suicide, and I hope you are, you really want to have that leadership of the tribe on whose lands your system is located. So if you are a system that's not tribal, however, you're working with the Seneca, and you have a group of Seneca people that you're working with, and your system is located in or near tribal land, you want to make sure that you have somebody from the nation involved in your work in some way, or consider having the creation of a position on your team, like a tribal or a cultural liaison on staff, who be part of your implementation team, but also be a link back to the tribe. And they can advise you on how to provide care that's going to be resonant with the people you serve, rather than, run them away. You really, it's important that people feel like the care is for them. You want to use tools to really communicate with people in the way they believe, in their culture, in their language. You use formats, storytelling, audio tape, whenever or whatever is appropriate. You want to be able to reach the community in ways that are resonant. You want to be able to um, provide care that people feel like they're being honored and respected. You want to understand, don't try to do a mental health status exam on us, because we don't make eye contact. It's considered disrespectful. And I know, I've been in the field forever, and I know that part of the mental status exam is, the judging of eye contact. Well, for us, that's not something that you really want to um, base a diagnosis on, because it really is cultural. You want to be able to be familiar with the way people articulate suicide. So if instead of talking about suicide prevention, you can talk about life promotion, or use words that are not going to be offensive. One of the tribes I worked with actually was able to go to NIH and change the wording on one of the screens that NIH developed, National Institute of Health, the ASQ, and actually changed the language, because the Diné relatives down in the clinic where they were working said that it was offensive, and they refused to answer the screen. And that's the first step to finding out whether someone is suicidal or not. You want to make certain that if you are in a place where you're treating Indigenous people, that they not only understand the policies and procedures around your particular program, around suicide prevention, around safer suicide care, so that they're competent and confident. And that's what our train element says: train a competent, confident, and caring workforce. But you also want to find out whether or not they understand the cultures of the people being served. So it's very important that they understand, as every single person in your agency, it doesn't matter if they're clinical or not, that even the janitorial staff, even your dietary staff, if you have that, everybody, your billing staff, understands what to do if they encounter somebody who may be experiencing suicidal thoughts and behaviors. A lot of systems have used badge cards. One system uses a mouse pad that people are looking down at and saying, okay, these are the things that I need to watch out for, even if they're not clinical. And you really want to make certain that people understand the cultures that you're working with. There's a workforce survey that we have on our major toolkit that you can put out to your staff to find out, where are the gaps in services? Where are the holes that we need to fill to ensure that everybody who comes in is treated as if they may be at risk, so that all those holes that people fall through are closed. But again, you need to understand that one size should not fit all. One of the things that folks feel most difficult for them is cultural humility. I've been in the field for almost 52 years, and I can tell you that if I come up to the Oneida Nation, and I actually have worked with Oneida, but the Oneida in Wisconsin, the Oneida Nation, I've been in the field forever, and I'm Indigenous, but I'm going to sit and listen. I'm not going to talk until I'm asked a question, because I need to be in the learner's chair. I need to understand that I don't know what the Oneida Nation's healing ways are until they tell me. So these are things that I need to listen to. It doesn't matter how long I've been in the field or how many letters I have after my name. I really need to have cultural humility when I work with any other tribe, because even though I'm Indigenous, an Indigenous Mi'kmaq. I'm not an Indigenous Oneida person. So I really need to have cultural humility. And that's one of the things that some people have difficulty with. So again, I want to stress this. Our cultural healing ways are thousands of years old. They're not researched. They're not in books. You're not going to find them in books, but they work, and they've worked for thousands of years, and we need to come back to them. You want to ensure cultural sharing between the tribe or the tribes that you may serve and the health or behavioral health care in the community. And this is not a time when we can have health fairs and open houses, and you can go to powwows and community events. It's not that time right now. But once we return to maybe the new normal, it really is, it means a lot when you go to a homecoming or to a powwow and you bring information about your health or behavioral health system, and bridge the gap between the community and the healthcare. It opens doors, believe me. People want to see you there, and they want to understand that you're part of the community as well. One of the things that we say is that you really need, in order to find out if you're working with someone who's at risk, you need to ask the questions. So the identify element tells us we identify individuals with suicide risk via comprehensive screening and assessment, and that those screening and assessment tools are evidence-based. Now, a lot of, I talked about it being taboo to talk about suicide in a lot of our systems, and some of the people who are on your staff may be from those tribes or tribal communities that you serve, and they have those taboos too. So you need to find that out, and if that's the case, encourage your Indigenous staff to talk about life promotion instead of suicide prevention. If you don't know how to do that, you can always consult with the elders of the tribe for suggestions. And they're the tribes up there, and I know that they're open, and I know that they're willing, and they're very open to talking. Now, some of you may know and some of you may not know that the Constitution of the United States is based on the Iroquois, what they call the Iroquois Confederacy. It's really the Haudenosaunee, which are the 6 tribes up there in New York. Did you know that? It was based on their doctrine, and the United States took that and created the Declaration of Independence Constitution, and that's what it's based on. So I had talked a little bit about the ASQ, and IHS, Indian Health Services up there is promoting the use of that for screening. And they were able, the tribe down in Arizona was able to actually get them to change the language to make it more resonant with Indigenous people, and to make it less offensive. So it's possible you can use these evidence-based tools and still make them resonant with the people you're serving. Again, my main goal here is to get this to people that you really need cultural humility when working with us, especially with the screening and assessment tools that weren't validated on us. So the suicide savvy culturally savvy clinician will ask questions in a way that's going to get people to answer them and not be offended by them, that will maintain their dignity and respect, while being able to provide safer suicide care. Realize that we're not help seekers. We're really not help seekers. So the more you can make people feel welcome in your system, the better. And acknowledge that it probably took a great deal of strength to even come in for assistance, because we're not really help seekers. Always ask about traditional forms of healing that show openness, that show you're open to getting the answer. Don't ask, you don't use traditional healers, do you? That's saying you don't want to hear that. You don't believe in it. It's okay if you don't believe in it, but do they believe in it? If they do use traditional healers, make sure you got some numbers, or in wonderful cases you may have somebody on your staff who is either a cultural liaison or a healer themselves and can actually provide support. um Always have telephone numbers. Some of the systems I work with, and this is kind of like a dream of mine, they actually have under medicine at this one hospital I worked with. They actually had a specialty clinic called traditional medicine. And in that traditional medicine clinic, there were 4 healers. And they had a hogan right there on the hospital grounds, and a hogan to for people in the north, people in the Northeast especially, you can equate that to a sweat lodge, but that's where they would do ceremonies, and they would do postvention for if there was a loss in the community, with the community. And they were right on staff. There was a clinic under medicine at this hospital called traditional medicine, and they had the healers were readily available. I will tell you, if you are working in Indian country at all, and I'm telling you, New York is Indian country too. If you are working in Indian country and you're working intensively with Indigenous people, having someone on staff or having someone readily available will open a lot of doors for you. Some tribal communities use the tip 59 from SAMHSA, which asks 20 questions about an individual's level of involvement with their tribal culture, to see if they really are, and what their healing ways are. So if you ask those questions, it kind of opens doors. Engaging people, using a pathway to care. All of us have pathways to care in our systems for different challenges that we treat. You can do that for suicide as well. You need to understand that people, not everybody uses a gun or a firearm to end their lives, especially in Indigenous communities. It's usually strangulation, rope or belt or something else. So you understand that when you're counseling around access to lethal means or lethal means safety. Be sure to connect with people right away. Stay close. If somebody does screen positive for a suicidal thought or behavior, you don't want to let them go without doing an assessment and leaving with a safety plan in their hand. There's a lot of free information on our toolkits and on the web around doing safety planning, and you really need to have a person who is who understands safety planning, but it doesn't have to be a licensed clinician. It could be peer specialists, it could be medical staff, it could be anybody who's actually helping this person do a safety plan. I know I'm coming up on on my time, so I want to go through this. But you want to keep in mind when you're doing treatment, our element of treat says you treat suicidal thoughts and behaviors using evidence-based treatment. Again, these weren't validated on us. So for us, it's more effective if you use the Western ways with our traditional ways. And I know in the state of New York that you have traditional nations. I know those nations, and they do have healers and medicine. And it really is what you believe can help. And you may not believe it, but the person who is coming for services believes it. I urge you to go in the toolkit for Indian country and look at that video from the Sootso Medical Center with the Diné Nation, and look at how they combine that Western medicine with their traditional medicine and show the people that they care about them. Telehealth is the way we do things today. A lot of folks are doing it and never did it before. So this is especially helpful for those who may be more remote and it's hard to get in anyway. But again, our folks are not help seeking in general. So telehealth is often a really good choice for us, especially if you're going to a health center and your auntie is like the person at the front desk, and you might not want her to know that you're experiencing a challenge. So telehealth is very effective. Memorandums of understanding with other providers, with traditional healers, are very helpful for Indigenous people, and especially critical for suicide safer care when you're looking at implementing zero suicide within a health system in Indigenous communities. And it's critical for tribally owned and health and behavioral health care systems that are not full service to develop really strong partners with the IHS service unit nearest you. You may not, if you are not serving Indigenous people, you may not even know it's there, but there's a service unit in New York that has representation, should have representation, or on your implementation team, and open lines of communication with that service unit. You want to use traditional healers, peer specialists, mobile health crisis teams for those who may lack transportation or have difficulty coming in for services. You want to make certain that that you have, if there's a gap in transportation, you want to ensure that a connection with the individual is maintained. You want to keep arms around that person, especially if they have screened and been assessed as positive for suicide risk, even if no treatment is available right then and there. You want to make certain that hands are on there. You want to create memorandums of understanding to ensure partnerships with both health and behavioral health providers within the community, and if necessary, outside of it. Please build relationships with the traditional healers nearest you and ensure they're represented on your teams. If you're doing caring contacts, and I love caring contacts, but reaching out to people with postcards and with symbols and images and words that convey hope and balance in life, and have symbols that they understand and they recognize. If you are working with someone who is proficient in their language, translating the messages into the languages of the tribe is so powerful, and it goes such a far way to actually uniting with that tribe. You don't have to put your return address on a postcard, and there shouldn't be any demands on that postcard or that letter. It's non-demand, it's in the language of the people being served, it's supportive, it's not a hate letter. It's designed to leave the door open. If people don't want or need treatment right now, it leaves the door open to be engaged. It's friendly and it's resonant with the cultures of the people being served. This is a great one from the Chickasaw Nation. You can't see the other side of it, but it's the messages are both in Chickasaw and in English. And that's a beautiful way to unite with the people you serve and to show them that you're respectful of their cultures and their traditions and their language. Not every tribe has a tribal site has an electronic health record. A lot of folks are still capturing it in paper and pencil. It doesn't matter, capture your data so you see what's working. Once it's captured, be sure to share that data with your staff, show them that what they're doing is working, and share that back to them so they know that what they're doing is working. You want to share out how the information is shared. You want to do it in your internal intranet. You want to do it in newsletters, but you want to share it back to the community as well. If you are a tribal system, or if you're not, if you're a system that's serving a group of folks from the neighboring tribes, you want to share that back to the tribe. Whatever the leader of that tribe is called, chief, governor, president, chairperson, and you want to share it to the tribal council of the community so they can see that what you're doing is working. Choose 4 or 5 data points, and usually I recommend process data. Make sure every single person who comes into your system is screened, and a positive screen leads to an assessment, and everybody gets a treatment plan, and everyone who is at risk gets treatment that's resonant with their level of risk. And you want to make certain that if persons do use traditional healers, that traditional healer or that medicine is brought in. Don't feel worried about it. It might not be in the book, but I'm telling you, it works with us. If you're IHS or led health or behavioral health system, you can use your CACs, and they're wonderful, the clinical applications coordinators, to help create reports and to make certain that what you're doing can be measured and improved at every step of the way. Even older electronic health records have some built-in functionality. And if you have an IT person or know of an IT person or can access the state, they can help you unlock that functionality, and you could start to collect information. Some of the tribally owned and managed and IHS-led health systems can use their clinical applications coordinator for that. Even the clunky RPMS system has a ton of functionality that can help you gather reports and do billing. So it's really doable. You want to share the data on the positive impact your work has had with your implementation team, and especially back to the community, back to the tribe, back to the traditional healers and the elders and the youth and the community at large. And you can publish that in tribal newsletters or presented at community gatherings, in infographics at health fairs. There's lots of ways to show the success you're having with providing care that's really suicide safer for the people coming in. Our people are really resilient. We're so resilient. And with our Indigenous ways of knowing, our people are going to grow and thrive and be healthy and strong. I want to say Walaliuk, or thank you all for being part of this journey today. You can reach me, and I'll give you my contact information right now. So you can reach me at salI@edc.org. We are on Facebook. We have a Twitter account, and you can make certain to contact us. I would love to talk with you more about how to make care safer in Indian country, and New York is Indian country. And I want to say Walaliuk, or thank you all for being in this presentation. It's a lot of information for 1 hour, eh? But I want to open for questions. Okay.
Okay, thank you so much. I'm getting a lot of questions, so I really appreciate everything. It was so fantastic. Thank you, Sade. Let's go ahead and jump into these questions. Are there any suggestions on the appropriate terminology that is inclusive, such as Native versus Indigenous versus American Indian, and etc.?
Most of us, American Indian, even though the government calls us that, most of us do not call ourselves that. You know, I would say, by and large, Indigenous is a way to frame the first people, and it's kind of inclusive. Many folks call themselves Native. Native American, not so much, and American Indian, definitely not. That's the language. If you call somebody Indigenous, people pretty much know you're talking about the first people. So that's kind of a term.
Okay,
That's,
thank
yeah.
you.
Mm-hmm.
Thank you. So I have another question. Thank you for an amazing and inspirational presentation. Would you say a little more about culturally sensitive and informed postvention practices for this community, or point us in the right direction?
Postvention for Indigenous communities, especially the more traditional ones, like the ones up in New York, are best held by a traditional healer, using medicine, using our sacred medicines of sage, sweetgrass, tobacco, and cedar. And I know, being, you know, a lot of the tribes in the Haudenosaunee have a lot of, we use the same medicines. And so I feel comfortable talking about this. It's usually done in a circle. Our circles are very, very sacred, as I said, and I see something about that. There's no beginning and there's no end, and you don't have to talk if you don't want to. It's usually done with a talking stick, and as you hold that until you pass it on, no one else can say anything. So you really talk your heart in that circle. But a lot of times, being able to sit together and to we do a lot of our healing in a circle together. That's how I got clean in a healing lodge in on the Maliseet Reserve up in New Brunswick, Canada, where we sat in a circle with the sacred fire, the sacred fire, taking our prayers to Creator, and that's very healing for us. So postvention, I've seen it done in many different ways, but it's always usually in a circle and usually in a sacred space. There's major lodges up there in New York, major lodges. You've got some very traditional, very powerful Indigenous people up there. And so the healing can be done in a lodge, in a circle, around a sacred fire that's made intentionally, and given medicines so that our prayers and our even our grief is taken by Creator. So if it's possible, you develop those relationships with those healers, and people will share. If you are culturally humble and you say, you know, we really want to help you and we really want your help. And I wish I had time to tell a story, but I know I don't. I know I'm out of time. But I really want to hear from you if you have other questions, and I want you to get that toolkit, best and promising practices for the implementation of zero suicide in Indian country. It's right on our zero suicide website. It lives right next to the main toolkit, and it's under adaptations. Yes.
Okay, thank you. Sade, would you go back one slide to where you have your other contact information? Or is this the slide with all your
That's the
contact?
slide. Yep.
Okay, okay, somebody had asked.
Yep.
Okay, would you share some examples of traditional healing modalities that Indigenous people participate in?
Yes. One of something I love, and I haven't done this since the pandemic, is Sweat Lodge. Sweat Lodge is probably one of our most powerful healing tools. It's done by a lodge keeper. It's not done by somebody new age who thinks they can do it. It's a very, very sacred healing tool. And it really is cleansing, both physically and emotionally, spiritually. I always say, if you don't see creator in a sweat lodge, you're dead already. I mean, it's just so powerful. Because there's prayer and there's song and it's just a powerful healing tool. The circle is also very powerful. If you do a talking circle correctly, and you don't have to be Indigenous to do a talking circle, the fellowship and treatment programs took that from us a long time ago, and they use that group circle for healing. And when we do it, there's medicine in that circle. There's a preparation of that circle before people sit down to share, and just that passing of that sacred talking stick. And it can be anything. It can be, as I said, we believe everything has a spirit. So it can be a stick that you've picked up from your walk in the forest, and it feels good to you. Or it can be a stone. It can be anything, but it's blessed, and it's saged, and those kinds of things are very healing. They're healing. And we do up in New York with the tribes there. They do lodges. There's actual lodges where they sing and they pray, and there's medicine that's shared. And these are closed to the people unless you are invited, and then you do what I said. If I've been invited up to the lodge, and I'm intending to go, when they start having them again, with one of my Onondaga friends. And but I will sit quietly, and I will listen, and I will wait until I'm spoken to. Those kinds of things where there's a lot of prayer and there's a lot of energy that's gifted to you by those healers. It's very powerful, very powerful. And I credit that with my own recovery, because I still do that.
Okay, thank you. This question is, would you please go over the power of circle healing? And I do want to say too that anyone who needs to jump off, you don't need my permission, but I'm just letting you know that the other presenter will have started by now. But Sade has beautifully given us her time here. And I think we have two more questions. So this is, we have this question and then just one more question.
Yeah,
so,
I think I just talked about that, Jenna,
yeah,
about the power of the circle, and because there's no beginning and no end, and Zero Suicide has adopted the circle now, and I'm so happy since I put it into the medicine wheel. It used to be linear. You remember that? The elements used to be, one under the other, like it was linear, but it really is a circle. There's a lot of power in that circle. Yeah.
There is, and there was a question about will your slides be shared? And of course they will. And in fact, that people can download them now. They are available now. So folks can just go right to your presentation and they can push download, and they can download your slides now, and they'll be available for the next 30 days on this site. And anyone who is wanting to go back and look at that slide, it's available now. And I think the rest of these, I think we do have answered all of our questions. Everybody else is just commenting on what a beautiful presentation it was and how much they enjoyed it. So
I'm just sad that I had to rush through it. I really would love to do like 2 or 3 hours on this, but I am available to come to your system, or and I've done a lot of work in New York. Some of the work on person-directed care that the city, New York City, changed all of their forms because of a workshop I did. No, it was a course I did at Brown University on recovery-oriented systems of care, and they brought me in and actually changed their paperwork and changed a lot of the language. This was years ago, but I would love to come and do some more work on implementing zero suicide with Indigenous people. So thank you. Thank you so much.
And okay, thank you, Sade. The compliments just keep roaring in, so soak them in, please.
Thank you so much.
Yes, so we'll go ahead and end this session. Everybody enjoy the rest of your day, and We'll see you soon. Take care.
Wilaliuk.
Yes.